Okay, guys, here's the next part of our introduction to clinical pharm, and this is the administration of drugs. First thing that you have to know, the 5 rights of drug administration. Right patient. Make sure that you've got the right patient. Check their wristband. Ask the patient for their name and date of birth or their phone number. Those are valid identifiers. Make sure you have the right drug. Compare the med, the container, the label, the med record. Make sure you have the right dose, the right route, and the right time. And then the last one is the 6th, really, but it's the right documentation. You record the administration of a drug immediately after it's given. Okay, so you don't forget. Is the following statement true or false? The 5+1 rights of drug administration include right patient, drug, dose, route, time, and documentation. And if you said true, you would have been right. Okay, so like I said, you can go in and go, hi, my name is Mary. I'm going to be your nurse. Can you please give me your name and date of birth? Or can you please give me your phone number? Right? Make sure you know that. Those are board questions. Okay? All right. General principles of drug administration. Never give a drug if you don't know what it is. That is it. That is the cardinal rule. Okay. You need a factual knowledge of every drug that you're giving. You need to know why it's being given, what the action is, adverse reactions that you have to be aware of, special precautions with administration, the normal dose ranges, because I have news for you. Physicians and pharmacists are human beings too, and they can make mistakes. Okay. You want to make sure you check your nursing drug guide. Okay. Always check it. Okay. To administer medication, a physician's order is essential. You can't give a med without having an order. And an order can be a standing order, which means it's something that is understood you will give. It can be a single order, just a one-time dose. It can be a PRN, give it as needed, but it still needs a frequency. So in other words, alprazolam, 0.25 milligrams, PO, Q4 hours, PRN for anxiety. Right? Can't just say PRN because what? PRN every 2 minutes, every 5 minutes? You get it, right? Some drugs are given once a week. So these drugs are designed to reduce daily doses. A good example, and this is one you have to know for the boards, alendronate. Alendronate. The trade name is Fosamax, but don't worry about that. Used to treat osteoporosis. And you should know that the patient, when they take that drug, they need to be in an upright position for at least 30 minutes after they take it, or they have the risk of getting erosive esophagitis. It'll eat away at the lining of their esophagus if they're supine after they take that drug. Okay. You always want to make sure you check written orders and compare the label of the drug with the MAR 3 times. Wash your hands and try not to touch the capsules or the tablets. Okay. Never remove a drug from an unlabeled container, or if the package is illegible, don't use it. Never crush tablets or open capsules, right? Unless you know that you can crush a tablet. You never, I shouldn't say never. There are some instances where a capsule can be opened, but typically no. Never, ever, 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 did I say never? Never administer a drug prepared by someone else. Example, you're working with another nurse and she goes, oh man, I just poured these drugs for Mrs. Jones and now I got to run. I got a phone call. It's an emergency with my kid. Can you just go and give him? Nope. Nope. I'll medicate her, but I'm going to go to the MAR and I'm going to pull the meds myself. Okay. Because I don't know what you poured. Okay. And make sure you're always on the lookout for drugs that have similar names, look alike, sound alike drugs. And there are lots of them. Okay. You always return the drugs wherever you got them from. If it's a unit dose, like a blister pack, remove the wrappings when the drug reaches the patient and chart immediately after you give the drug. Never leave a drug in a patient's room and walk away, ever, ever, ever. Okay. Every time you give a drug, follow the 5+1 rights. Okay. If you see an order that's questionable, okay, just make sure you question it. Because again, if you don't and something happens, that's on you. Okay. The most common medications where errors occur are insulins and heparin. That's an anticoagulant. Most common. So drug errors. Patient can get the wrong dose, the wrong drug, an incorrect dosage of the drug, a drug by the wrong route, a drug at the wrong time. Remember, you're the last defense against protecting these patients from the cemetery. If there's an error, don't give the drug, report it immediately. Okay. So I'm going to start at the bottom. The Institute for Safe Medication Practices, they're the ones that come up with medication error reporting program. What that is they look at all the data from all the hospitals in the country over the course of a year to see what kind of med errors were made, a root cause analysis to find out why the med mistake was made, and then what can we do so that it never happens again. Okay. And then there's national patient safety goals, and safe drug administration is in them. And that's from the accrediting body JACO. They're the accrediting body mostly for hospitals. There's also ACHC, that's for long-term care, subacute, hospice, home care. And then there's CHAPS, which is only for home care and hospice. And this is where the national patient safety goals come from, to make sure that we're doing everything we can to keep our patients safe and healthy. Okay. Question: is the following statement true or false? The intravenous route is the most common route of med administration. If you said false, you would be right. Oral. Oral is the most common. Okay, so let's go piece by piece. Oral administration. It's the most frequent route. And oral forms can be tablets or capsules or liquids. Sustained release, extended release. These drugs will usually have SR, LR, XR, ER at the end of their name. You can't crush them, you can't break them. They're meant to be broken down in the body and in the intestine over time. They're usually good for 12 to 24 hours. Okay, so remember, don't break them, don't crush them. And your responsibility is always to verify the drug, know what it does, identify the patient, make sure they've got water to drink, and never leave it at the bedside, right? Never. Then there is parenteral, okay? Administration of drugs by parenteral route. Parenteral is an umbrella term that encompasses subcutaneous, intramuscular, intravenous, and intradermal. There's also intralesional, intraarterial, intracardiac, and intraarticular. Don't worry about those. Worry about the four that I just mentioned: subcutaneous, intramuscular, IV, and intradermal. Always wear gloves. Always use standard precautions. Always cleanse the patient's skin with an alcohol prep. Okay. So when we're doing subcutaneous drugs, you're putting the drug into the fatty tissue between your skin and muscle. Okay. Your responsibilities: single, multiple sites. You always should rotate sites to prevent something called lipodystrophy. Know that word. Lipodystrophy is scarring of tissue if you keep on injecting in the same spot over and over again, where eventually scar tissue builds up and that site won't absorb any drug that's injected into it. Lipodystrophy. Okay. Where are subcutaneous injection sites? Well, the abdomen, right? Posterior upper arm. In other words, this part, this fatty part, the inner thigh. It's got to be in fatty tissue, not muscle. The needle length and angle of insertion, it's a 45-degree angle, 22 to 28 gauge, which is the width of the needle, 1/2 inch to 3/4 inch length. Okay. And you need to know this. So intramuscular, 22 gauge to 18 gauge. Remember, the bigger the number, the smaller the needle. The smaller the number, the bigger the needle, the wider it is. So an 18 gauge is a pretty wide needle, and it should be 1/2 inch to 1.5 inches long. And IMs go in a 90-degree angle. What are the sites? Ventrogluteal for adults, which is the hip bone, and it's right here. Okay. The vastus lateralis for infants, which is the thigh, and the deltoid is the other one, the other site for adults. Then there's something called a Z-track. A Z-track prevents backflow of drug into the subcutaneous tissue. Some drugs can stain the skin. Example, iron, dextran. If that's given IM, it can turn the skin brown. So you're going to do it via Z-track. What is a Z-track, you ask? I'm glad you asked. You pull the skin. Let me try to do this so you can see. So you pull the skin to the side of the injection site, insert the needle at a 90-degree angle, push in the medication, remove the needle, and then release the skin. Okay. And it prevents staining. Make sure you know that. Okay. And then IV. That's where we're putting a drug right into your blood. We have a needle into the vein. So with IV, we can do a slow IV, a rapid IV. We can do what's called a piggyback infusion, right? Into an existing IV line. We can use intermittent venous access devices. There are lots of different ways to administer IVs. There are controllers, pumps, there's gravity. I will tell you this, that you will probably never hang an IV to gravity. Most of the time, you're going to be using a pump of some type because they're more accurate. And a pump will alarm you if something's wrong. What could be wrong? There could be air in the line. There could be an occlusion, a kink, blockage. The battery on the pump could be low. The infusion could be done. Or for whatever reason, that rate that you've got put into the pump is just not able to pump effectively. So you have to troubleshoot it. Okay. Nursing responsibilities when you're doing IVs. You always make sure you document whatever the fluid is, whatever the drug is, immediately after the start of the infusion. And you're always going to check the rate and inspect the insertion site. If you should see swelling around the needle or around the site where it enters the vein, that can be extravasation or infiltration. And when we talk about IVs, we'll get into more detail about that. So don't worry about that just yet. Intradermal. What do we use intradermal for? Things like PPDs, right? Allergy testing. It's usually given on the inner part of the forearm, right here. Try to avoid an area where there's moles or scars or, any kind of pigmented skin. It's a 1 milliliter syringe, 25 to 27 gauge needle, super skinny, 1/4 to 5/8 of an inch, super short needle. And you put the needle in at a 15-degree angle, okay? 15-degree angle, which is very close, right? Close to the skin, 5 to 15, actually. You don't aspirate the syringe, you don't massage the area, you go bloop, and you're done, okay? Then we can give drugs through the skin and mucous membranes. So topical, transdermal, or inhaled, okay? Topical, transdermal, or inhaled. Topical means that they act on top of the skin, like an ointment, right? Or like otic drops, ear drops, or ophthalmic drops, eye drops. They're considered topicals. Make sure you know that. Make sure that you understand the action of the drug and make sure that you administer it the way it's supposed to be administered as per the directions. Okay. Transdermal, these go through the skin to the fatty tissue below. These are slow to work. Okay. And the dose of the drug is literally implanted in a little kind of a bandage looking thing. Okay. And the way it works is that once that patch is applied, slowly over time, the drug goes into the bloodstream through the fatty tissue, slow and steady, reduces the possibility of toxicity. Okay. So, but there's some things to keep in mind with transdermal application. Okay. Always wear gloves. Always apply the patch on clean, dry, non-hairy, or as little hair as possible, areas of skin. We do not shave the person anymore. Like if they have a super hairy chest, we used to shave it, but that runs a risk for infection. Do not shave. You can get scissors and make the hair a little shorter if you need to. Always rotate sites. So if the patient had one on the left anterior chest wall, then when you change it, it should go on the right anterior chest wall. And when you remove the old patch, fold it into itself because people will dumpster dive. This is true. Looking for fentanyl patches. Okay, so stop. And commonly used sites, the chest, the flank. I want to add the abdomen and upper arm, fatty areas. Okay. Mucous membranes, inhalation. Think about a nebulizer or a metered dose inhaler, a puffer, right? So it's drug droplets or vapor or gas that gets absorbed through the mucous membranes of the respiratory tract. You can use a face mask, a nebulizer, positive pressure breathing machine. For the nurse, just make sure that you're following the instructions and instructing the patient properly so they know if they're going to self-administer. So whenever you give a drug, you record it immediately, document immediately. You're documenting if it's IV, the flow rate, the site used, any problems, vital signs before and after. You're going to evaluate and record the patient's response and also observe and record any adverse reactions and frequencies. Okay. When we talk about the patient's response, a great example to that is pain medication. You go in the room, the patient says, my pain is a 10. You document, patient states pain 10 out of 10 on scale. You give them their pain pill. You go back in a half hour later. How's your pain? Oh, it's a 3 out of 10. All you have to document is the time and then patient states pain 3 out of 10. That's all you have to write. You don't have to write drug was effective or any of that. That tells me that it was effective. Okay, short and sweet, only facts when you document. Question, is the following statement true or false? Commonly used sites for transdermal administration are the chest, the flank, and the lower arm. And the answer would be false. Commonly used sites are the chest, the abdomen, here, add the flank, and the upper arm, okay? There is, at the end of this PowerPoint, some real handy injection information. It shows you the needle angles. There's 5 to 15, 45 for sub-Q, 90 for IM. It shows you the sites. There's the deltoid, ventrogluteal, and there's the vastus lateralis for infants. Subcutaneous injection sites, where fatty tissue is, like for insulin. Needles, the anatomy of a syringe, okay, so that you know what you're looking at. And there's a nice little chart with the different sizes, and you need to understand that, okay? Well, that's enough for this one. Next. All right, guys, I will see you with the next video, okay? Keep coming back for more. And if you want something special, tell me.